बाल वाल बढ़ा लिए?
हाँ यार, अभी क्या करें।
कोविड का असर है।
बहाना है कोविड का। I always wanted to grow hairs, अभी मौका मिल
Okay, good, good. Looking like a real professor.
गया।
Good evening, Dr. Rajiv. This is Dr. Arun Goel here.
Hello, Dr. Goel. How are you?
I am fine. Nice to see you.
Good, good. Seeing you after some time.
Yeah, I know it's been a fair amount of time.
हाँ. And Dr. Vaishali is there.
Yes, Dr. Vaishali.
डॉक्टर किशोर सिंह ने भी ज्वाइन कर लिया है।
अच्छा, ठीक है, चलो विल वेट। और ये YouTube पे भी आएगा ना लाइव?
हाँ,
Yes,
the
yes,
YouTube पे
yes.
भी live है. It is active, the YouTube link.
अच्छा, YouTube link is active.
हाँ, if you want to check it, you can check it, but it right now.
I'm just checking. हाँ यार, YouTube link is active. So YouTube में तो रिकॉर्ड भी होता है ना?
हाँ, YouTube में रिकॉर्ड होता है, and I am also recording locally. If there's a problem, then I will create a local recording also.
Okay, okay. So YouTube में भी also it will be recorded.
Now it will be available regularly.
Okay.
So we have that channel on which it will be available.
Okay.
वेलकम डॉक्टर किशोर।
So 12 people have
Good
entered the
evening.
waiting room.
Yeah, I know. So I was just waiting.
Good evening.
हाँ, let more people और 5 मिनट थोड़ा टफ
हाँ, exactly. We'll
हाँ.
आप
enter.
बेटे अपनी स्लाइड्स वो कर लीजिए।
अभी
हाँ,
तो
you should check your screen sharing, so that will
हाँ,
be right.
अभी तो 5:55 ही हुआ है.
Yeah, I
Okay,
know.
let me just check my screen share. एक
डॉक्टर मुनीश इज आल्सो ज्वाइनिंग। मुनीश गैरोला।
Okay. So Dr. Ramesh Sarin is there. उनको भी हम लोग वेलकम कर लेते हैं.
डॉक्टर गांगुली को भी कर लो।
Dr. Kishore.
Good evening.
गुड इवनिंग।
Good evening. So I would request you to check your slides also for sharing. Dr. Rajiv is checking. After that you can.
मेरी स्लाइड्स दिख रही हैं अभी?
हाँ, दिख रही है
हाँ
sir. We
दिख
can
रही
see
हैं,
your
दिख
slides.
रही हैं।
फुल स्क्रीन पे ना?
Yes,
यस।
sir.
Okay. Okay. Good, good, good. So I am just minimizing my slides.
Yeah, sure. So you'll have to stop sharing. Yeah.
अच्छा, I stop sharing now.
So that Dr. Kishore can check his slides. So.
अच्छा, okay, 1 second. कितना अच्छा ऊपर चला गया वो वाला। हाँ, कभी कभी उसका वो जो है ना ऊपर चला जाता है। 1 second. हाँ, तो इसमें ओके, मैं स्टॉप शेयर करता हूँ अभी। हाँ,
Yes, yes.
ओके।
Okay, Dr. Kishore, you can check your sharing now.
मैं तो स्लाइड बना नहीं पाया।
अच्छा,
अच्छा।
हाँ,
ओके।
थीसिस और उसमें ही लगा रहा ना। थीसिस के कल थीसिस जमा हुई है सबकी।
So you will speak without the slides?
मेरा स्किप ही कर दो।
But पैनल में तो पार्टिसिपेट करेंगे ना?
हाँ, नहीं पैनल में तो रहूंगा मैं मौजूद।
क्या था इनका टॉपिक, क्या था आपका?
इंटरनल मेमोरी रेडिएशन।
उसमें क्या चीज था? व्हाट वाज
In fact, he was supposed to talk about the technology and how to reduce morbidity in the internal memory nodal irradiation.
तो मैंने तो वो कवर ही नहीं, वो स्लाइड सारी हटा दी मैंने तो। आई हैड आल्सो स्लाइड, मैंने अभी वो आई कांट पुट देम बैक सो क्विकली।
और सर स्लाइड्स नहीं डाल सकते, थोड़ा सा टॉक में जितना कवर कर सकते हैं।
मे बी डॉक्टर किशोर सिंह यू कैन जस्ट से अबाउट इट थोड़ा बहुत। आप
जी
आप बोल दीजिएगा।
हाँ, वैसे बोल दीजिएगा सर, बिना स्लाइड्स के जो है।
ठीक है।
I think now we have how many people? Already 27, 28. I think people join कर रहे हैं अभी.
हाँ
अभी 6 बजने वाला है वो और by 6, 5 है तब तक हो जाएंगे.
हाँ, I think we'll just start by that
Yeah.
time.
I think we now have 37 participants. So you let us know whenever to start.
Yeah, another 2 minutes or so. We'll just
Okay.
wait and yeah.
Okay. And for the panel, others are there. Dr. Anushil is there.
Dr. Anushil will be joining. He told me he'll be a little late. Dr. Munish has joined.
Okay. So how is the Delhi scene now? The number of cases have come down. You all can feel that in the hospitals. Corona, COVID.
I think Bombay और Delhi का तो same ही चल रहा है. Number of about 1,000 cases a day. Similar
Yeah.
pattern.
Yeah.
थोड़ा सा flatten तो हो रहा है दिल्ली का curve. So time will tell.
Yeah. But cancer services are disrupted in so many places, isn't it? The cancer routine cancer services are.
In fact, Delhi में Dr. Kishore Singh might tell about the government sector, private sector में तो कोई disruption नहीं है.
Okay. But number of patients would have come down, I would imagine.
Yeah, they have come down. जैसे हमारे यहाँ पर भी जो patient distance से आते थे, public transport is not working.
Yeah, that is what.
बस अपना transport है, they are coming.
Yeah, those who have their own transport, they are coming.
Yes.
Dr. D.N. Sharma, he will join a little late or?
No, he was supposed to join now.
एक बार उनसे पूछ लो एक बार just and then we'll start, I think.
Okay. I'll talk to him.
चला दो हम स्लाइड्स बना लें चला दो.
Hello, Arun.
Hi, Dr. Rajiv, how are you?
Somehow the other, my video is not coming. Are you able to see?
We can't see. You and there's lot of echo also.
No, are you able to see my video?
No.
I don't know why the photo is not coming.
Maybe he has two devices open. He has logged in from phone and laptop both. That's why the echo is coming.
The desktop.
नहीं आपका बहुत echo आ रहा है
So he may be having two devices, I would imagine. Either
yeah,
phone plus desktop or something else.
Hello, Dr. Bhavna.
There's so many webinars these days, it is, I'm doing one more webinar tomorrow, actually 2 more tomorrow. So it is
I know.
becoming an overdose. And
Definitely there are a lot of
a webinar, you don't realize that, there could be many, sometimes without even...
Acha, Dr. D.N. Sharma is here. Welcome.
So,
He's here.
now,
Hello, Dr. D.N. How are you? You are on mute, so...
Okay. Am I audible now?
Welcome. Yeah, you are audible now.
Oh, thank you very much.
I think if you want to check your slides just once that you are able to share, after that we'll start with Dr. Rajiv. Then
Okay, fine.
Just check once if you can.
Okay. My good evening to Dr. Rajiv sir and others as well. Dr. Kishore Singh sir, good evening, sir.
Good evening. Good evening.
good evening, Dr. DN.
Good evening, sir. Good evening very much. Good evening, sir. I'll just check whether my slides are okay on the share
Yes.
screen. Yes.
Yes, we can see your screen now.
Okay, fine. I'll just open the slides and then maybe you can let me know.
Yeah, absolutely.
You can see, no? Okay, so I'll minify that and I'll stop the stop sharing then.
Yeah, sure. Stop the screen sharing.
Fine. Okay, fine.
Okay. So I think Dr. Dinesh, we should take it forward. It's already 18:06:05. Yeah. So a very good evening to all of you. I am Dr. Arun Goyal. I am a surgical oncologist at Max Vaishnavi. And we are organizing a series of events basically focusing on topics of interest in the field of breast cancer, generally small 1.5 hour events on areas where there is some controversy, things which are otherwise not commonly discussed. So 2 weeks ago, we had done one on papillary lesions of the breast. And this time we have taken from the field of radiation oncology about regional nodal irradiation. This is an area where there is a lot of debate and controversy within our tumor boards and in conferences, and also we thought it might be a good area to cover. So with that, I would like to welcome all of you and hand over to my colleague, Dr. Dinesh Singh, to take the proceedings forward. Dr. Dinesh, please.
Hello, good evening, everyone. And I welcome the entire faculty and all the delegates in this webinar, in this series of webinars. Today, we will be discussing about the regional nodal irradiation in breast cancer. As we all know, this is a very hot topic, and many times we are confronted with a lot of clinical situations, in which we keep on thinking, whether this patient should receive radiation to the internal mammary or not, should axillary radiation be given or should not be given, what are the different benefits and what are the potential pitfalls in these cases. So for that, we have got eminent faculty to take us through this. And I will request all the delegates to keep them on the mute button. And I invite Dr. Rajiv Sareen. He is a professor in the Tata Memorial Hospital, Mumbai, both branches. And he will be talking about the internal mammary nodal irradiation. And does it has any benefit to the patient? And also I will request him to touch upon some of the techniques to reduce the morbidity of that. Dr. Sareen.
I'll just like to add one more thing to all the delegates. For questions, I would request you to put your questions in the chat box which is there. And we would like to handle the question answer along with the panel discussion which will be held after the talks. Thank you.
Okay. So good evening, everyone. And thank you for giving me this opportunity to speak on something which is a little odd, internal mammary node. This was something which we used to take a lot of interest, then we completely ignored it, and now we are forced to again take interest in this aspect. And I will, in the presentation, I had 20 minutes allocated, but there is no slide presentation in the next talk, so I will take maybe a little more time. So the topic that was given to me, internal mammary irradiation, node irradiation, is there any patient benefit? So I am actually focusing more about what is the clinical benefit to the patient, because when we discuss, as Dr. Goel very rightly said, of late, this has become a point of discussion, what we should do with the lymph nodes. Otherwise, lymph node management was very standard. Just the surgeon will go and remove the nodes in the axilla, and radiation oncologists would treat the supraclav if required, and there was a high risk of recurrence, and sometimes axilla also, depending upon the if there was this thing. And now internal mammary, and I'll start with an anecdote. About 30 years ago, when I joined Tata Hospital as a resident, we were not giving internal mammary nodes irradiation in those days, but patients who were just 3 or 4 or 5 years follow-up, I was very intrigued when you opened there, it was written patient had a PGA. PGA means, juniors may not know, peripheral glandular area was irradiated. Sometimes certain dose, and some patients were there who had only PGA, even chest wall was not irradiated. They had been given radiation only to their peripheral glandular area, because it was thought that the tumor was small, so the risk of chest wall recurrence is less, but there was axillary burden or something else. So it was done. And I'm talking of 1980, 89, that time that radiation can cause damage to heart was also not known. It's the juniors may find it very odd. We used to think that heart is a radio resistant organ because it is made of muscle, and cardiac muscles they can withstand. So we thought. So there was someone called Sternswald. He published a paper that although post-mastectomy radiotherapy improves locoregional control, but it does not affect survival, is not improved. So he postulated that because of the lymphatic RT, the immunity goes down, and because of that, it is all, and then later on we knew that it is the effect of radiation on the heart which sort of causes all this problem. And that is the whole issue. So now, subsequently, what happened is then at some stage, we completely not only stopped giving radiation to internal mammary, we stopped talking about internal mammary radiation. No one actually talked about, why bother? So that it was no benefit, and we knew that whenever internal mammary is to be irradiated, it can go give dose to the heart. And by that time, everyone had become hypersensitive to the late effects of radiation on the heart. And the pendulum had swung from one end to the other end. When we didn't bother about giving radiation to the heart, and mostly in earlier days it was direct anterior field which will go and go through the heart. Heart was just behind the internal mammary nodes. To the extent that we even stopped thinking about irradiating this, primarily for the fear of giving higher doses to the heart and causing late effects and death. Not just late effect, but death. So what I will cover. So in terms of when we talk about clinical benefit from say a curative or adjuvant cancer treatment, so how all we define clinical benefit? So first thing is, the best case scenario is the cancer is cured with minimal toxicity in majority of the patient that you treat, and a near normal lifespan is restored. I mean, that is the best a cancer patient may want, and that is the best a cancer doctor can do, that you cure the patient. Lifespan is like you can do it for differentiated thyroid cancers or for some early cancers, many. So that is the best case scenario. Then what happens is that is what the more in adjuvant setting, cancer is cured but with major toxicity in many patients, and lifespan is increased in some patients. When I say some patient, then again we go by the prognostic factors, predictive factors, so many other factors to identify the subgroup of patients who are likely to be cured because of addition of this adjuvant treatment. It could be a adjuvant chemotherapy, adjuvant radiotherapy, whatever it is, or more extensive surgery, dissection of lymph nodes. So then that's how the guidelines come, the indication for this modality of treatment for these patients. But again, the reason why we are doing this is to cure patients. Then unfortunately, what happens more frequently in the real life when with adjuvant treatment, recurrence or metastasis is delayed, that means the DFS is improved, with or without quality of life gain. Actually, sometimes quality of life could go down also, but the treatment does not increase the lifespan. That means no overall survival benefit, and it may or may not have financial toxicity plus. Some financial toxicity will always be there, but sometimes the financial toxicity could be more than just slight this thing. And then unfortunately this also happens in real life. It should not happen that with that treatment there is no improvement in either in DFS or OS or QL. Toxicity may or may not be there, and financial toxicity could range from minimal to very high financial toxicity. So you would imagine such treatment will never be given by any doctor or never will be taken by any patient. But in real life it happens. Sometimes patients ask for it because something has to be done. So now I am showing in this slide, it's just to show, which is already everyone knows, that the incidence or the chances of finding the internal mammary node is highest in tumors which are in the inner half of the breast or behind the nipple central quadrant, and in those in whom axillary nodes were positive. Again, this is a common sense, and these are the studies in which they had done the lymph node dissection, so extended radical mastectomy. So and that's where they had found. So as you see, patients who had a IMN node positive will be high if they had axilla positive and they were medial or central quadrants. Almost half of these patients had this, whereas those who had axilla negative, even in there also, it's not that no one would have internal mammary nodes. In medial and central quadrant, maybe 10 to 20% would have that. But this was mostly in the older series, because now no one does these extensive surgeries. In the modern series, in axilla negative, the IMN node involvement is under 10%, and in axilla positive, it could be anywhere from 50 to 30%, depends upon the number of axillary nodes, the quadrant, and all those things. But exclusive IMN involvement is seen in smaller number of patients, and in these studies was found that the internal mammary nodes, they were positive. Mostly they were in the first 4 spaces or the first 3 maximum. If you extend to 4, vast majority of the lymph nodes were covered. So I have made this slide. I just wanted to show things. So this is the IMC nodal control with treatment. So you could give conventional RT. So this is the dose. I forgot to make this line. So this is the increasing dose. We all know these curves, and this is the probability of control. So conventional RT, advanced RT techniques, so proton or carbon ion. It's not that advanced RT technique would have a higher chances of control. If you give that much dose, ultimately it is photons or gamma rays or even protons. I mean, carbon ion but in internal mammary, because there's not so much of hypoxic element, so carbon ion will not necessarily increase the cure rate for the same equivalent dose. Now, this was for IMC control, but what happens, this is, I've plotted, I've just made it up, but this is what I think would be, is serious cardiopulmonary toxicity. So with lower doses, when the chances of controlling IMC node is low, you hardly have any clinically significant cardiopulmonary toxicity. But when you go to a higher doses with conventional technique, you see this would rise steeply, and at some stage you would be actually causing more harm than benefit. But not everyone, sometimes, as I've told you initially, we used to see patients who were there, some patients who have been given direct anterior field, and even many of the clinical trials, not all of them had died of heart attack, but their rates were increased quite significantly. So of course, with the modern techniques that we use now, I have not listed. I mean, there's so many modern techniques there. Using from partial wide, tangent, to using DIBH or other techniques using VMAT, where you can actually contour the internal mammary nodes, you contour the heart, you contour the left anterior descending coronary arteries, you contour the anterior myocardial territory, and based on all that, you then see that you control the dose to these regions. And with that, if most of the times you are able to control the dose to the internal, to the heart and other structures and lung, where it will not be very high. But of course, sometimes it exceeds. Can someone please mute?
Excuse me, all the audience requested to please mute your.
Okay. So you can mute also, Dr. Goel, from you also have the control. If you know who's talking, you can mute them. Okay, so now this thing comes, so to control, but many times what happens, despite the advanced RT techniques, you are not able to, like for the other cancer sites, when we are giving RT in curative or adjuvant setting, we want it to be receiving at least 95% of the prescribed dose. But for IMC, even in the randomized controlled trials, they allowed up to 85% of the dose was also accepted. 90% is, very commonly accepted, 90% of the prescribed dose. And the reason was that despite the use of advanced RT techniques, in many patients, we were exceeding the dose to the heart, and now the dose, safe limits of dose to heart, we are basically making it very tight. We are basically making our lives more difficult, but I think it's better to be safe. Then of course, if you have proton, if the patient is lucky to afford a proton or a carbon ion, or you have that center and you have space for that patient for in carbon ion or proton, the dose to the heart and the lung would be much less because there's no exit dose. So this is what it is. So based on that, one should say, well, every patient should receive RT or IMC if they require, should receive on a proton or carbon ion. And if that is not possible, then with advanced RT technique. So that is what it should be. But the third thing which I am sort of drawing is survival benefit from IMC RT. So we will not say there is no survival benefit. If at all, it will be a small survival benefit in the green line. And survival benefit will be the same, whether you use conventional RT, whether you use advanced techniques, or whether you use carbon ion. I'm talking of cause-specific survival. Cause-specific survival, that means breast cancer mortality would be same. Only thing is maybe, so everywhere else it is low, and in of course, because here the dose, this is there. So maybe there's a slight edge in such situation where the cause-specific mortality may be more than the mistake. But the problem is here is that we do not know who are these patients. Who are these patients who will fit in there? Who are these patients who would have, less things? So the case selection as of now, if you dissect, we will go to the studies later, they are quite arbitrary. And when I say arbitrary, of course, there is some trial, but anything that you take from a trial, if it does not have, you do not have sufficient reasons to extrapolate that, it is a arbitrary. So you can say, well, it is from that trial, but was that trial really asking that question? Can you make that inference, and does it sort of hold ground? So that is the question. So this is what I am saying, that IMC nodal control, if you give high enough doses, the IMC nodes will be controlled, unless until they are very big, large lymph nodes, especially microscopic dose. But with conventional techniques, if you try to give a dose beyond, say, 45 gray, 40 or 45 gray equivalent, you will give quite high doses to the heart and lung. With advanced techniques also, in some patients with an unfavorable anatomy on the left side, you will give quite significant doses. Of course, with proton and carbon ion, you can control, but you have to think at what cost. The logistics and financial toxicities also are there. But at the end of it, the main bottom line why you have that nagging doubt you discuss is because you know that a few patients would get survival benefit, but which are those patients? I think that is a open box. So now I'm just see what has changed here. Instead of IMC, I've written supraclavicular nodal RT. This is supraclavicular nodal RT. So in supraclav, again, chances of disease control, both are lymph nodes. And here the toxicity, instead of cardiac, it is severe brachial plexopathy or serious pulmonary toxicity. Of course, that is never very high. In conventional, I have shown it little higher because sometimes to give adequate dose, you may have to prescribe at a higher depth, or you may have to use a opposing field also, so it could be higher. And the survival benefit from SCF-RT again would be, of similar magnitude, maybe same as with IMC. But the difference here is, if you look at the previous one, the serious cardiopulmonary toxicity with IMC RT, the red line was much higher. With SCF, the red line is quite low. So no wonder we do not agonize whether to irradiate SCF or not and what techniques to use. If we feel there is a possibility that this patient may have a subclinical disease in the supraclavicular node based on the quadrant or the axillary nodal involvement, we just put one anterior field. Initially, it should be just at surface dose, and we realize that it should be at depth, and now we contour the supraclavicular fossa, and when we contour, we realize that sometimes you have to use a posterior beam also in some cases, maybe 10% patients. And then when you start contouring the brachial plexus, sometimes you realize that the brachial plexus is actually getting more than 100% of the prescribed dose. So in a few patients, you may have to, control the brachial plexus dose. But even 50 gray equivalent is quite a safe dose. But when we treat head and neck or lung, we are much more brave in, firing the brachial plexus. But in breast, somehow, we are much more conservative when we are treating a breast cancer and the brachial plexus. I think because of the junctional miss and overlap, people have had brachial plexopathy. It's not because the dose the brachial plexopathy gave, brachial plexus got because of the dose prescribed, but the wrong technique used in which brachial plexus was, covered fire. So supraclav, again, no one would ask for. In some patients in supraclav also, advanced radiation techniques would benefit, but in majority of the cases, conventional RT techniques, direct anterior field prescribed at a certain depth would be okay. And I can't imagine a place where carbon or proton would be useful for treating supraclav. I mean, you can show dosimetric superiority, but it's not. If you want to spare the more of the thyroid, probably you can do that, more of the hemithyroid. So treatment options for internal mammary. So one is surgery. Again, a lot of surgery was done. Dr. Goel may remember, he must have studied that what surgeries people would have done. It used to be morbid, and it is seldom performed now. Sometimes in our institute, some patient who has on the imaging, we see a internal mammary node, and we loathe to sort of give them high doses of radiation, because for them just giving 50 gray equivalent may not work. So our surgeons, at the time of doing a mastectomy or a BCT, if it is inner quadrant, they will just dissect the upper few spaces and remove them. Then IMN external beam RT, there are several technical issues. Again, I'm not going to details. And the main issue is, as I showed in the earlier slide, is about the risk and the benefit. So who will be at risk? Actually, that we know more, better who will be at risk from that based on the anatomy and the technique that you can use on a patient. The debate is on who will actually have the survival benefit, not just IMC nodal control, survival benefit. So again, why I'm saying that, because to get a survival benefit from IMC radiation, that patient has to either have an isolated failure in IMC, sometimes you don't pick it up, or the IMC recurrence, and IMC recurrence is not the nidus for secondary spread. We have the spectral theory of cancer, which Hellman gave. So Fisher gave it is always systemic disease. Halstead had said it is always a loco-regional disease, and so Hellman had said that it is actually a spectrum. Some breast cancer, उन्होंने hack कर लिया था. They had become co-host and they hacked it. चलो आपने बोलने से चले गए. शरीफ हैकर्स भी होते हैं, देखो. अच्छा, अभी क्या हो रहा है? Can you see the screen?
We can see, sir.
We can see.
अच्छा, I can't see much. Okay, you can see now. Okay, so where were we? So IMN external RT I have said, and IMN brachy I am not going to talk much, because this is a little odd thing that we have been doing. We have done quite a bit, but outside TMH I don't think there's much experience, and that is not the mainstream. So in terms of the evidence for benefit of radiotherapy for internal mammary nodes, so the retrospective studies have been reported with conflicting results, and because they were, as expected, confounding factors were there. And few series reported very infrequent IMN recurrences, and actually because you can't feel them, and there was no cross-sectional imaging done routinely. but there have been 3 randomized trials. So I will just briefly talk about these randomized trials. So the first one is the French study, which I will show later, but this is the only study which randomized between radiation to chest wall plus medial supraclavicular lymph node RT. So that all patients received chest wall RT plus supraclav RT, and the experimental arm was the same, plus or minus was internal mammary RT, and these are all mastectomy cases. In the other 2 studies, they were basically the control arm had only breast or chest wall radiation, and the test arm had supraclav plus IMC RT. So what was being tested was the combined effect of supraclav and internal mammary, yes or no. So this is a main difference. And actually in this slide you can see, because later on I won't go into the details of the I have slides. So in the French study, all were mastectomy cases. 3/4 were 3/4 were node positive, 1/4 were medial and central quadrant, and the dose that they gave was 45 in 20, which was equivalent to around 50 in 25. In the other studies, MA20 and the EORTC study, the dose was again, this was all BCT cases here, predominantly BCT cases, and the dose majority of them were node positive, and the dose was in this 45 and 25 for the MA20, which is equivalent to around say 40-42 gray with 2 gray equivalent. And so mind you, the dose to the internal mammary would have been even lower. And in this, the dose was 15-25, but they accepted 85% of the dose to the lab. So after that, I am directly coming to the guidelines which are there in the NCCN guidelines. And why I'm showing this is because the guidelines come from where? Guidelines come from the studies which have been done and randomized trial. That's how guidelines come, especially when you talk about NCCN guidelines. These are the only 3 studies which have happened, and I have not given the critique of that. So the NCCN guideline now, and it has all changed recently in the last few years. I keep checking every couple of years. So now they say for TN2, which is more than 4 or more nodes, internal mammary RT should be part of, you should be treated. For N1, which is 1 to 3 axillary node, it says strongly consider RT to supraclav and internal mammary node. Okay, so that says strongly consider, and of course in node negative, it is not recommended. For post mastectomy, again for N2 disease, it's a clear recommendation for IMC RT. For 1 to 3 nodes, you strongly consider. And if negative node, if it is tumor is more than 5 centimeters, that means T3 or N0, consider RT. So that is there. And for margin positive, plus minus. Now for NCCN, for LABC also, it is advised internal mammary lymph nodes. Now the NICE guidelines, so where they have come later. Earlier they were sort of ambivalent. They say about radiation to nodal areas, consider including. So I don't know what the terms are, do not offer or consider including IMC within the nodal radiotherapy target for people with node positive macrometastasis invasive breast cancer. And but they also say that what I put in this red box, how the recommendation might affect practice. This recommendation is likely to need a change in practice for many centers. That is an issue. There will be some impact on resources in order to implement this recommendation, because additional training will be needed and local protocols will need developing, which is true not just in England. If it is true in England, in India, you can imagine that will be so much more important. However, the long-term impact on resources will be minimal, because everyone there has moved to image-based planning and 3D and beyond maybe 3D conformal radiotherapy. Some additional planning time will be needed, but there is no impact on length or number of radiotherapy sessions. So when you say some additional planning time, I think it is an understatement. It is more than some additional planning time. And length of sessions. So the issue is many of these patients, especially left-sided, would require DIBH. So DIBH is more resource intensive. You need to train the patient on the machine, and everything else is there. You have to see the setup. So it is obviously more resource intensive. So the Danish Breast Cancer Group Guidelines 2016. So they have said due to lack of evidence, international practices differ, but now they have found that it helps. But they also had a lack of clarity on the patient population to be treated. Now, all these recommendation I showed, this was based on the just three studies. Rest everything was retrospective or prospective non-randomized studies. So look at the French study, which this is the only study where the only difference was IMN RT versus no IMN RT. So this was done over a period of 7 years, 1400 patients, and the primary endpoint was 10-year overall survival. So they thought that by giving this RT, they could improve the overall survival from say 40% to 50%. And they had subgroup analysis based on tumor location, and the SCF and the apex was treated at a fixed depth of 3 centimeter, and the dose prescribed was 45 in 18. But one center used a different dose, and they treated with photon electron combination or a cobalt at 3 centimeter depth, and they treated actually 5 spaces. So the French were doing a little bit more. And what you see, unfortunately, after all these years, you realize that overall survival is no different, and the p-value is 0.08. And I mean, it's not a very small study. I mean, it is close to how many patients are there. So it is a 1400 patients, and for radiotherapy, 1400 patients just for internal mammary is by no means a small study. It's quite large. And they did not find a difference in late effects, but the cardiac evaluation was not done systematically. And I think one of the criticisms was that this study was underpowered. They were too optimistic in terms of 10-year gain in overall survival. So they thought from 40% to 50%. Then their control arm actually did much better than it was assumed. The control arm did better. And the target volume that they used was excessive because they treated up to 5 spaces. So this was a negative study, but of course you can always find some, something in that. So now this was the study of IMC to medial supraclav. This is the EORTC study, Putmans and all reported. So this was a much larger study, 4,000 patients. So almost 3 times the patients in this thing. Primary endpoint was 10-year overall survival, and they're expecting 4% difference in OS with RNI. So from 75, it will improve to 79%. That's why it required 4,000 patients. And it was stratified whenever you want to treat supra or IMC, quadrant and axillary nodes have to be a stratification factor. But what was the testing was that in addition to the radiation to the breast, whether you are treating regional nodes or not. Axilla, that was taken care of by surgery. And so that was the test. It was not just IMC, it was medial supraclav and IMC versus no regional nodal irradiation. And they covered 3 to 5 spaces depending on the tumor location. And actually this was the first study which had a strict QA, and that's how they realized that so many centers were failing the QA. But of course this study was started in 96, and 96 in most of the Europe, radiotherapy was reasonably well advanced. It was all image based planning. Unfortunately, this study also overall survival benefit was nil. I mean, you can say 1.6% difference, but it was p.06. It was not did this. And disease-free survival was improved again by only a small little 3% improvement in disease-free survival, and this was statistically significant. So, to treat to avoid one relapse and death was 30 and 39 patients. And when you say to avoid a death, it was not even a statistically significant. And of course, in late effects, they did not find anything. So it was negative for the primary endpoint. Cardiac evaluation was not done systematically, and it is not basically testing the effect of only internal mammary irradiation. It is testing the effect of IMN plus supraclav versus no IMN plus supraclav. And non-breast cancer mortality data at a longer, say 20 years follow-up, that is still awaited. Now, this is the MA20 study, which again, most of you are familiar with this. This was again a fairly large study, and this same sort of stratification, and they also had, so they had supraclav, IMN and axilla versus no regional nodal irradiation, and the dose they used was what is before the start trials, what was standard dose, which was 15-25, and they used either partial white tangent or photon-electron combination, and they had actually used cardiac shielding wherever it was required. Again, if you look at, unfortunately for overall survival, there was no significant difference. Hazard ratio was 0.91, but you see it is confidence interval, it's going up to 1.13. And of course, disease-free survival and isolated disease-free survival, these were there, but actually distant disease-free survival also improved, so that was an indication that it was having some effect, but that effect was very small and it was not translating into survival benefit, even though we were comparing SCF plus IMN without SCF or IMN. So imagine if it was only IMN, SCF was routinely treated, whatever these differences you are seeing in terms of even loco-regional disease control and DFS, it would have been, it might still would have been there, but it would have been even smaller. So whenever you treat, there would be some toxicity. So some patient would have skin toxicity. Some patients would have, cardiac toxicity, because they very carefully control the dose to the heart and lung. That is a redeeming feature, that there was not excess cardiac toxicity. And same way, second cancers. Again, this is reporting so many second cancers, which does happen when patients are cured of the cancers. Many patients do develop second cancer for various reasons. And that was not different between the two arms. So that was actually reassuring. But as my colleague Tabassum, she has published, so the jury is still out. So while there are, so this she has summarized quite well. So uncertainties about the benefit on overall survival, variability, where IMC is localized, how much to cover, what dose to give, and are modern techniques safe in terms of long-term safety? And is the benefit that we are seeing, is it because of IMN irradiation or combined IMN plus supraclav irradiation? Because we routinely treat supraclav whenever required. I mean, there's no doubt about it. And the concern is, there are several concerns about it. So, and the technical challenge. So clinicians should judiciously decide need of IMN based on patient anatomy, comorbidities, and conventional risk factors. So this I was telling you, we in Tata Hospital in 2005, we started doing this as a pilot study. Then we've done almost 500 patients, because we were, in those days, most of our chest walls we used to treat with cobalt. Even now we treat many patients on cobalt. So we dissected the second space, and we cannulated the vessel. And because the lymph nodes around the vessel, that's how we do the contouring, also irradiated that prescribed at 1 centimeter from the center of the catheter. And so that controlled the dose to the heart. And I won't go into the details of that, because this is no comparator arm, but as you can see that both for operable and locally advanced breast cancer, you get a reasonably well disease-free overall survival. But in absence of a comparator group, which is a randomized comparator group, these numbers means nothing. It could be purely because of case selection and censoring. So I will not make much out of it. So now I am coming to what is the joint ASCO-ASTRO and the SSO, which is Society for Surgical Oncology, their focus guideline update. And so the question is, should regional nodal irradiation RNI include the internal mammary nodes and or supraclav axillary apical nodes when post-mastectomy radiotherapy is used in patients with T1-2 tumors with 1 to 3 positive axillary nodes? So we're talking of T1-2 and N1. So they say panel recommends treatment generally be administered to both the IMNs and supraclav axillary apical nodes in addition to chest wall or reconstructed breast in patients who had positive axillary nodes. And they also recognize there may be subgroups that will experience limited, if any, benefit from treating both these nodal areas, but there is insufficient evidence to define these subgroups. So actually I would put it the other way around. I would say there are only a small subgroup who would benefit from IMCRT, not the other way around, that who would not benefit. There's a small subgroup which would benefit from that. I think the whole challenge is to identify who are these, because the number needed to treat, even if you take the EORTC trial. So 1 out of 40 patients, if suppose the same magnitude of effect is there with IMC and supraclav combined, 1 out of 40 patients benefit. So two or three patients out of 100 are actually living longer because of radiation to this area. And if you have a large sample size, maybe this was also not true. But even if we assume it is true, which are these 2 or 3 patients? Because to cure those 2 or 3 patients, the department goes through a lot of things. If there's a department where resources are not constrained, patients are paying for the cost, or the government is providing a LINAC and the planners and the radiograph technicians and the physicists who have all the time in the world, definitely. I mean, even as long as you know that you will not cause them long-term damage, you do that. But unfortunately, very few people are in such fortunate position. Even if they have those resources, are they truly benefiting that patient? I think there is a question mark on that. So the practical implication, as I was mentioning, the infrastructure and resource implications. So now every patient will need a LINAC. We actually, many of our, in Tata Hospital, earlier 90% of our patients would be treated on Cobalt, 10% on LINAC, because we have both the machines. Now, more of chest walls also get treated on LINAC, but many chest walls we have managed to treat them based on proper image-based planning 3D, that we feel that Cobalt, we can treat them. But if we have to treat the IMC, then I doubt if any of our patients will be treated. Throughput will be affected, and the main challenge lies in reproducing quality treatment in real world. In a trial setting, when that is what you see, in the real world, what will happen is an issue, and then you need long-term surveillance. So when I say risk of ischemic heart disease, this is a paper from you all know Sarah Darby, that with each increase in each gray in mean dose to the heart, the risk of serious coronary event increases. Of course, there is criticism of this. Mean dose actually, I feel, means nothing. Depends on the technique. The mean dose to the heart with a volumetric treatment versus mean dose to the heart with just tangential fields, and mean dose to the heart with a direct anterior IMC field. You may have same mean dose, but the damage that you could do with that mean dose to the anterior myocardial territory, to the coronary arteries, could be very different. So, but this is just to show that heart dose does matter. This I'm showing you real life. This patient I had seen a few years ago. So as you can see, all the astute clinicians would see that there is a hypo and variegated pigmentation in this, and this would only happen because it is not just a match line fibrosis. So this kind of skin appearance you get when there has been a moist desquamation, then only you will see this kind of skin appearance. That means there had been an overlap between, and you will not, with the dose that you get, if at all you get a moist desquamation, you get in the inframammary fold or in some areas of the boost, not in this region. That will happen only if there has been an overlap between the supraclavicular and the tangential fields of the breast. And what I had noted, match line and SCF tangential developed. So the patient said that she had moist desquamation and now has shown deep pigmentation and no features of brachial plexopathy at that time. But I kept wondering that this patient, whenever I had seen her in May 2016, I had seen, so everything else was perfect. So this is just an example that the quality control in real world. So if you are doing it on this thing, suppose if you are treating internal mammary, and there if you are doing that, you are just firing the. So some of you would know in UK there was a RAGE group, radiotherapy action group, and there were many women who had developed brachial plexopathy. So it went up to the House of Lords. A report had come, and it's a very informative report how they took it, and they took it seriously. It changed practice. So it was because of the change in the position between the change in the arm position between the treatment of the supraclavicular fossa and the breast or the chest wall, the brachial plexus, and the technologists or the radiographers in UK, they're excellent, outstanding. Even when I was there in early 90s, they were so good. If there's a mark or a tattoo, almost always they would match within few millimeters of that. There will never be hardly ever be where you're off by a centimeter. Again, I'm showing this case so that just as a sobering thought, this lady had a post-mastectomy radiotherapy with 3D conformal RT. I won't tell the hospital. In November 2015, she came to us some years later. You can see that she has severe depigmentation, and this will not happen unless until there's a very high dose has been received in this region. You can see pulmonary fibrosis in this apex and in this field. So this patient, rest of the chest wall, the skin looks absolutely fine. And so she had moist desquamation leading to hyperpigmentation in SCF tangential field match line. She also unfortunately developed esophageal stricture. So much was the overdose. So this I'm talking to you, and she had this thing, and she had symptomatic radiation pneumonitis. And for her, we had to refer her to MedGI for dilatation for the esophageal stricture. You may have never heard for breast RT someone develops a esophageal stricture. We started her on Visolone. I said we should start if she develops symptoms of pneumonitis. And I was very skeptical, and this patient actually hasn't come back to me. I don't know what has happened. I was very skeptical that she would develop radiation brachial plexopathy, which will be an irreversible. So this actually happens, and they have been all treated with 3D conformal. It is not with simple skin marking. So I come back again to this. So IMC, so this, remember this graph, it is there. And what I'm saying is that who will get the survival benefit by IMC and who would benefit from the advanced techniques? So basically we have to discern out these kind of patients, and in which patient you require more advanced techniques, and there may be odd patients who actually may require even proton or carbon ion. So I think that is a whole challenge of to go through the process to identify patients who will have survival benefit, and then identify patients who would have unacceptable late effects with a given technique, use a higher technique that is possible for that patient. So I'm summarizing it. So in terms of clinical benefit from this thing for IMC, so as of now, the evidence is whatever the guidelines might say, recurrence metastasis is delayed, which is DFS is improved. With or without quality of life gain, no one looked at quality, but treatment does not increase lifespan. So there is no survival benefit. With or without financial toxicity. So we know that moment patient requires a DIBH and everything else, patients are charged more, and rightly so, because the resources which are required, the training which is required, the machine which is required, it costs much more than giving a simple bitangential field. So, and of course, God forbid if someone requires a proton beam or a carbon ion, the charges will be quite much. So I think this, in terms of what is available, this is a benefit what is there. So with this, I would end my talk. And whatever we do is as part of a group, and Tabassum and Rima have really helped me and with some of the slides. Thank you.
Thank you, Professor Sari. It was a very exhaustive and informative talk, and you have touched upon all the aspects of the IMC radiation and what are the potential benefits and what are the risks. So each person has to be evaluated whether the patient needs this technique and this IMC radiation, whether this will be going to add to the benefit to the patient, or it will only add to the morbidities. Thank you so much. Questions we will be taking at the end, and you can post your questions on the chat. We will be taking them in the question answer sessions. And hello, Narendran, can you stop your display? So now our next faculty is Professor Kishore Singh, who is the head of department of the Maulana Azad and LNJP hospital. I will invite him for his expert comments on the internal mammary radiations and the techniques, the benefits, and the pitfalls about it. Dr. Kishore Singh, please.
Yeah. By the Dr. Sarin, and my job has become much easier. So I will try to focus on how to reduce the morbidity. PMRT is now a part of the armamentarium. It includes supraclavicular, infraclavicular, as well as internal mammary nodes. Effectiveness has been established. It reduces the spread of micrometastasis along the drainage site, as well as subsequently lower the risk of distant metastasis. So radiation is the must. But it remains a matter of debate that whether higher doses are delivered to heart and lung will increase the mortality. So there is a question mark on the use of IMN RT. Average dose from meta-analysis is the 5.7 gray to the whole lung and 4.4 gray to the heart. With outdated techniques, heart doses may be reaching as high as 8 gray. But with the availability of 3D CRT, forward IMRT, and inverse IMRT, especially with the IMRT, these doses has been reduced. But the shot in the arm is the heart sparing technique of breast radiotherapy. With these modern intensity modulated RT and volume VMAT, we are able to reduce the doses significantly both to the lungs as well as heart. And with deep inspiration breath hold, we have been able to use it successfully without increase in the mortality. In proton, we can do it even without the breath hold. So currently we should use it for heavy nodal disease, central and medial tumor, or one with the high risk N0 to N3 disease. New technique which is available and been practiced with success of 96% is the internal mammary sentinel lymph node biopsy. Although it has not been popular, but it has been shown to do the personalized IMRT, internal mammary node radiation, by doing the biopsy. Thank you.
Thank you, Professor Kishore Singh. And very aptly, you have put things in perspective for everyone to understand. And to proceed further, I will now request Professor D.N. Sharma. He is head of the radiation at All India Institute of Medical Sciences. And he is going to discuss about the role of radiotherapy to axilla in those patients in which axillary dissection has been done by a good oncosurgeon. Dr. D.N. Sharma, please. Dr. D.N. Sharma, are you there?
Give him a call.
Okay, I'll just call him. Not there. Then maybe
Dr. Sharma has come. He has come.
He has come. Dr. Sharma, are you there?
Yes, sir. I'm here, sir. Please, sir.
Yeah, Dr. Sharma, now kindly start your presentation.
Okay, fine. Okay, that's good. Okay, fine. Give me just 1 minute time so that I can start sharing the screen. Okay.
Yes.
Can you see the screen, sir?
Yeah, we can see it.
Okay, so good evening to all, and thank you very much, sir, Dr. Arun and Dr. Dinesh. Thank you very much for inviting me. It's my pleasure. My talk is very simple, simply because the axillary irradiation has been simplified because of certain trials and certain literature. The topic for me is irradiation of the axilla after axillary dissection, when and how. And I suppose I'm supposed to talk of the axillary RT once the axillary dissection has been done, and not the sentinel node biopsy. But I will touch briefly on that aspect because that's a shifting paradigm. So I will touch upon that as well. We all know the importance of the axillary nodes in the carcinoma breast. As we know that axilla receives 97% of the lymphatics from the breast. And in the clinically negative axilla, the chance of microscopic disease is about 30 to 40%. And in early stage breast cancer, like T1, T2 breast cancer, there's a risk of about 10 to 40% of the micrometastatic disease. And therefore, it is very important, vital to know the axillary status. And how do you know that? We have to assess the axilla by various methods. First and foremost, of course, the clinical examination. A good clinical examination is very, very important. Although it may not be reliable as compared to other techniques, but still it is a very essential step for the assessment of the axilla. In the imaging modalities, we have PET scan, we have MRI, but their sensitivity is not very good. Ultrasound, of course, has a good sensitivity, but of course, the surgery is the gold standard for knowing the axillary status. It can be done in the form of either the sentinel lymph node biopsy or the axillary lymph node dissection. Now, I think just to reiterate, what is adequate axillary dissection, since the role of radiotherapy is to be discussed only after the axillary dissection. The adequate axillary dissection is defined as the removal of the minimum of 10 lymph nodes from the axilla. That's how we define the adequate axillary dissection. And this is just to show that how the lymph nodes are stationed in the axilla. Lateral to the pectoralis minor, we have level 1, and then beneath the pectoralis minor, we have level 2, and then the level 3 is actually above the or medial to the pectoralis minor. This is how the axillary lymph nodes are stationed in the axilla. Now, just to touch upon that, how the axillary lymph node dissection is important and how does it help in the management of the breast cancer. It provides very useful information for the prognosis of the patient, and that is through the number of nodes removed and the number of nodes positive and the perinodal extents. These are the 3 parameters that the axillary dissection provides us for the management of the axilla, and it guides us the to frame the adjuvant local treatment as well as systemic treatment. It has a therapeutic value as well, because it eliminates the disease from the axilla, and therefore it improves the local control and it improves the survival as well. But there is a recent declining trend of the lymph node dissection practice. There is very significant literature emerging about the shifting paradigm from the surgery to the radiation treatment. Various alternative options for this the lymph node dissection are the sentinel lymph node biopsy and the axillary radiotherapy. Undoubtedly, the axilla has to be addressed. There is no second opinion about it. It should be addressed either by the lymph node dissection, or by the sentinel lymph node biopsy, or by the axillary radiotherapy. Something or other has to be done from these modalities for addressing the axilla. It cannot remain unaddressed. And although I will just discuss the role of RT in the patients who have been dissected, where the axilla has been dissected, but I think this is one important area which we need to touch. This has been a very significant development for radiotherapy, that the emerging literature indicates that the lymph node dissection can be replaced by the axillary radiotherapy. And I will not go in the details of the all trials, but one important trial which I think we all know is that Amaros trial, which was published in 2014. It has a very decent sample size, 744 patients. All the patients has sentinel lymph node biopsied, and they were positive, and then they were randomized to either axillary lymph node dissection as usual, and the other arm had the sentinel lymph node biopsy positive plus the axillary radiotherapy, and no surgery was done, no dissection was done. In these series, the axillary recurrence rate was quite low, 1.7% versus 2%, and it was not certainly significant. The survival was similar, and therefore there was no inferiority in the axillary radiotherapy arm. There was one significant finding in this study was that the axillary RT has less complication as compared to axillary lymph node dissection. So therefore, this trial was quite categorical in the sense that the axillary surgery can be replaced by the axillary radiotherapy. There were other studies like ECOSOG, AUTOSOR, IBCSG, and ATREM as well. But most of the trials compared the sentinel lymph node biopsy versus the lymph node dissection. Although they are comparing the lymph node biopsy versus the lymph node dissection, but silently these trials have been taking the benefit of the tangent port radiation treatment, which significantly treats the part of the axilla, especially the level 1 and level 2. So even though it was like sentinel lymph node biopsy alone, but these patients were treated by tangent ports, and the quite a bit of the axilla was treated by the tangent ports. So they have the benefit of the RT has been silently elicited in all these trials, and all these trials showed that it is safe to replace the axillary lymph node dissection by the sentinel lymph node biopsy plus the tangent port whole breast radiotherapy or the axillary radiotherapy. This is just to show that how the high tangent ports can cover the significant portion of the axilla. As you can see, this is a usual tangent port, but the high tangent port can cover almost all the level 1, level 2, and even the part of the level 3 lymph node as well. So therefore, the tangent ports provides a very good coverage of the level 1, level 2 lymph nodes. Now, the first part of the talk is that when to treat the axilla by radiotherapy. Now, routinely the axilla is not irradiated if the adequate dissection has been done. This is, I think, unambiguous, and this is followed in most institutes. Axillary RT is indicated only if the dissection has not been complete or adequate. That means if less than 10 lymph nodes have been removed, or if the axilla is positive with the extensive extranodal extension, or the number of lymph nodes is more than 4 after the neoadjuvant chemotherapy, because a lot of people are giving neoadjuvant chemotherapy even in early breast cancer as well. So these are the indications of the axillary radiotherapy. This is just to show that why we don't need to treat the axilla in general after the adequate axillary dissection. This is a trial from the MD Anderson group, and in this there were 1,031 patients, early breast cancer, and median follow was 116 months. And in this trial, the axillary recurrence rate was very, very low, 3%, and even the SC failure was also very low, 8%. And the axillary failure in our series from the IRCH in a sample of 1,200 patients is less than 1% in early breast cancer and about 6% in the locally advanced breast cancer. So the axillary recurrence rate has actually gone down in last couple of years, and therefore is not more a concern for the breast cancer team. Another study with a very good sample size, 8,106 patients, enrolled in 13 RCTs, and in this also the axillary failure rate was 1.3% if the lymph node dissection was more than 10 lymph node removal, and less than 5% if the lymph node removed was less than 7, and if it was 1 to 3 lymph node positive, then it was 3.2%. So all in all, the axillary failure rate has been very, very low. So therefore, in routine, we don't need to treat the axilla by the radiation treatment. Couple of more trials, but I will not go in details because now it is very evident that the axillary RT is not required if the dissection has been more or less adequate. Now, this is another emerging and challenging field that a lot of patients nowadays, even in early breast cancer, are receiving neoadjuvant chemotherapy, and that actually makes the job of radiation oncologist very difficult, because then the axillary status is spoiled or distorted, and it's very difficult to choose whether to treat the patients by axillary RT or not. So far, the literature is divided, and our policy at IRCH is that even though there is a complete pathological response with neoadjuvant chemotherapy, the treatment is guided. That means the axillary RT is guided by the initial clinical disease, and therefore we do not take into account how the patient has responded and what is the status at the time of the surgery after neoadjuvant chemotherapy. And this is just to show that there is some conflicting data in this. This is a trial which was published in JCO in 2004, and this was actually an analysis of 6 consecutive prospective trials of neoadjuvant chemotherapy at MD Anderson Cancer Center, and 4 trials had used doxorubicin and 2 had taxanes. In this, the PMRT was used, which included RNI as well, and the patients who received, number of patients who received radiotherapy was close to 557, and the patients who did not receive RT at all was 150 patients. So it was a comparison of the two groups. The two groups were not really matched in terms of the sample size, but it was realized that the irradiated patients had more advanced disease, and the 10-year actual rate of local radiation recurrence was higher in the patients not treated by the radiation treatment. 22% without radiation and 11% with the radiation. It was significant. Therefore, it says that the even though the neoadjuvant chemotherapy has been given and there was a response in these patients, but the post-mastectomy radiotherapy and axillary lymph node treatment and the other nodal areas had a benefit in terms of the 10 years overall survival rate. Another trial which had a different view. This was again from MD Anderson Cancer Center, and in this the authors found that in stage 1, stage 2, actually there is no benefit of adding the radiation treatment once the neoadjuvant chemotherapy has been given. But in stage 3, there was a significant improvement in the local region control, which was like 7.3% recurrence rate with radiotherapy, and 15.7%, 33% without the radiation treatment. So this says that in stage 3 or the locally advanced disease, the post-mastectomy radiotherapy has some advantage, but not in the early stage after the chemotherapy. So therefore, with this kind of the conflicting literature, our policy is very clear that the patients who have been given neoadjuvant chemotherapy, the decision of adjuvant radiotherapy is actually based on the initial clinical stage. This is how the lymph nodes are mapped. This is level 1, level 2, and level 3, and this is IMC, which Dr. Sareen has talked about. Now the second portion of the talk is that how the axillary radiotherapy should be done. What are the various techniques? Now this is first and foremost the 2D technique, which is still widely practiced in most part of the world. The advantage being that this is simple as compared to other techniques, and it's widely available as well in most centers. People having cobalt machines still doing the 2D techniques, and we know the results that is still a good technique to practice. The other techniques being 3D conformal radiotherapy, then IMRT, VMAT, and even people have tried even proton also of late in the management of the nodal irradiation. Dose of radiation, I usually recommend 45 to 50 gray by conventional fractionation, and I am the one who does not encourage hypofractionation for the patients who have got nodal irradiation. For chest wall or the whole breast is still okay. I have no problems with that. But if it involves the nodal irradiation, axilla, and the SCF, then I usually don't practice the hypofractionation. It may be right or wrong, but I don't practice hypofractionation if the nodal areas are to be treated by radiation treatment. This is just to simply show you the field. Usually, once we decide for axillary RT, the SCF is automatically the area to be treated, because if the patient has an indication for axillary RT, then obviously patient will receive the SCF RT as well. So it's usually a common field covering the SCF and the axilla. And this is just an X-ray picture, which we still use for the 2D technique. But important thing is that the areas should be shielded, which are not unwanted areas should be shielded for the treatment. And this is again to show the all 3 levels, level 1, level 2, and level 3 in the SCF, of course, the IMC. And these are the borders of the various fields. I will not go into details, but the upper border is actually same as the SCF field, which is the thyroid groove. The middle border is just across or 1 centimeter across the midline. Lateral border as the insertion of the deltoid muscle or insertion of the deltoid muscle or the humeral head. The lower border is to be matched or it coincides with the upper part of the tangent port. Post-axillary boost, I usually don't practice. If you have the high energy 6 MV, megavolt 6 MV or 10 MV, then it's not required. Yes, for cobalt it might be required, but most of the patients are usually nowadays on the linear accelerator, so we don't require post-axillary. But if at all it is to practice, then these are the borders. I will not go in details of the borders of the post-axillary field. This is the 3-field double isocenter technique. We have one isocenter for the the whole breast or the chest wall, and the separate for the SCF axilla. This is one technique which people of late use. And this is how it looks like. You can see the 2 tangent ports and then one field for the SCF and the axilla. Similarly, we have a 3-field with a single isocenter technique where with one field or we treat the medial and then the other field the lateral tangent, and then with the separate field and separate isocenter for the with a single isocenter we open the SCF and the axillary field. These are their contouring guidelines mainly from RTOG and from ISRO as well. We follow the RTOG guidelines, and I am sure most people follow the RTOG contouring guidelines. These are the various nodal volumes to be treated as per the RTOG guidelines, and these are the various contouring guidelines based on the anatomical landmarks and the boundaries. Although these are, I think most people know that they are available freely on the website. So I'm not going to go into the details of the various contouring details, but just to show you, this is level 1, this is level 2, sorry, this is level 3 actually, this is level 2, and this is level 1. And this is one of our patients. Our surgeons usually, mostly they put the clips even for the axilla as well. It makes our task very simple to define especially the level 1 at the lower end, where exactly we should take the lower end. So this helps us in delineating the level 1 axillary lymph nodes. So we are lucky in that way that our surgeons are in habit of putting the clips in that also. This is just to show the dosimetry. This is a VMAT plan. As you can see, a single arc covering both the breast and the SCF and the axilla, and you can see the distribution here. Most of our residents do not demarcate or contour the level 1, level 2, level 3 separately. They just mark one CT, one volume, and maybe for each, because we have high volume center. So due to shortage of time, they do not separately contour level 1, level 2, level 3 axillary lymph node. They just draw one CT for the axillary nodes. It would be unfair if I don't talk about the brachytherapy for the management of axilla, although it's rarely practiced. This is one study from the Sloan Kettering, where the patient had a recurrent axillary node. Recurrent means the patient has been dissected earlier and patient received axillary RT previously, and then patient developed a recurrent in the node. So, and this is important for even the surgical colleagues as well, that when we dissect the recurrent node, and which is not that easy, because there will be some fibrosis post-surgery and post-irradiation, and there might be some issues for the microscopic disease left behind in the axilla. And therefore, radiation these patients might be a little difficult, because axilla is one area which doesn't tolerate the radiation very, very well, being in the vicinity of the lungs, and in the left side because might be the other areas. So what they did is that they put an applicator during the surgery in the tumor bed, and then they gave something like 15 gray intraoperative radiotherapy dose, and then rest by after the 3 to 4 weeks down the line with another 25 gray, which is not that difficult, So this is one intraoperative brachytherapy technique for the recurrent axillary node, which if we encounter this sort of problem, we can practice that. So just to summarize and conclude, there's a shifting paradigm from axillary dissection to the axillary radiotherapy. And if axilla is adequately dissected, then routinely no RT is required. And precisely the indication of axillary RT are if the dissection has been inadequate, if there's a perinodal extension, and if the patient has received the neoadjuvant chemotherapy, especially locally advanced breast cancer. And in future, the role of axillary RT is likely to increase, because slowly, although surgeons are not have not really accepted the MRS trial, at least in India, I don't see any surgeons practicing and accepting this. But yes, there will be a shift in future. We hope that there will be a shift, and therefore the role of radiation therapy will be much more important. But it's a challenge for us, because then you have to precisely define the lymph node, axillary lymph node areas, and the onus will be honest, because so far we have been blaming each other that the lymphedema is because of the surgery. We say because of surgery, and the surgeon said because of radiotherapy. But now it will be purely because of the radiation treatment, if at all there is a lymphedema. So the onus is entirely on us. Whatever the recurrence or the complications and the local control will be attributed to the radiation treatment. And therefore, it is very crucial to identify the axillary nodal areas so that we can precisely treat them without causing the issues like lymphedema and brachial plexopathy. I will stop here, and thank you very much, sir.
Thank you, Professor Sharma. This was a very exhaustive and very informative information about the axillary radiotherapy. And it is important to ponder upon that if an axilla has been dissected adequately by an oncosurgeon, then unless there is a very precise indication to irradiate, it should not be irradiated. Otherwise, it adds on to the lymphedema in these patients.
Right, right.
The questions we'll take now, and now is the time for a few case discussions. And for that, I will invite my colleague, consultant Rekshi Chaudhary, which is a consultant with me in my department. And she will now take over and invite panelists for doing the case discussions. Dr. Rekshi Chaudhary, please.
Thank you, sir. Very good evening to everyone. So let me just share my slide first. So, fine. So after these wonderful discussions, now we are very much clear about the indications, about the techniques and everything about the regional nodal irradiation. Now let us have some repercussion through some examples. So we'll have a panel discussion about the regional nodal irradiation. And for that, I will first take the opportunity to invite our esteemed panelists. First of all, I invite Dr. Kishore Singh, who is professor and head Maulana Azad Medical College.
Namaskar.
Good evening, sir. Now I invite Dr. Rajiv Salim. He is professor at TMH. So, are you there?
Yes, I am there.
Now I invite Dr. D.N. Sharma, professor at AIMS, Delhi.
Thank you very much.
Welcome, sir. Now next, Dr. Manish Gerola, who is professor and HOD at Rajiv Gandhi Cancer Institute.
Yeah, I'm HOD, not professor. Thank you. I'm here. Professor is DN.
Sorry.
DN
Next,
is professor.
For us, you are Professor Manish, more than professor.
No, you are professor.
Now, Dr. Anushil Munshi.
Hello, everyone.
Sir is at Manipal Hospital, Delhi. Dr. Kanika Sharma, ma'am is at Dharamshala. She is a HOD at Dharamshala.
Thank you, Frekshi.
Welcome, ma'am. So now let us start with some cases. I have deliberately cut short the history and clinical details of the case so that we can have more time for discussion. So if at any point of time somebody has any query regarding the clinical details and pre-operative findings, please let me know. So to start with, the first case is of a 55 years lady who presented with lump in her left breast in the lower inner quadrant. After complete history and thorough clinical examination, it was found to be a 4.5 into 3.5 centimeters lump in the lower inner quadrant. She was investigated fully, imaging, and after that she was designated to have clinical stage T2 and 0. Biopsy was grade 3 invasive carcinoma. She underwent upfront surgery in the form of breast conservation surgery and sentinel lymph node biopsy. In sentinel lymph node biopsy, one lymph node was found to be positive and it was decided to proceed with axillary lymph node dissection. So the post-operative histopathology was PT2, tumor size was 4.2 centimeters. 2 lymph nodes were involved, one in sentinel and one further lymph node was found in axillary lymph node dissection. There was no LVI, no PNI, no extranodal extension. She was ER/PR positive and HER2 positive. She received adjuvant systemic therapy, and after she completed chemotherapy, 2 weeks later, she presented to the radiation oncology OPD regarding further management. So my first question goes to Dr. Kishore Singh. Sir, what would be your prescription for this patient regarding radiation therapy? Dr. Kishore Singh, sir, are you there?
Axilla has been dissected.
So sentinel, yes, sir. Complete axillary lymph node dissection has been done. Tumor was present in the lower inner quadrant. The size of the tumor was 4.5 and on final histopathology, it was 4.2 centimeters. 2 lymph nodes positive.
So only high risk area is the whole breast and internal mammary radiation because tumor is medial and grade 3.
Okay, sir. Fine. Now I want to ask Dr. Rajiv Sarin, sir, do you agree, or is your radiation prescription different from what Dr. Kishore Singh has said?
Okay. So well, I agree, we have to treat the breast and we have to treat the supraclavicular fossa because that 2 nodes are positive. Earlier for supraclav fossa, our threshold was 3 or more axillary nodes, but now we treat for even N1 disease. For IMC, I gave a good, half an hour lecture that it's a debatable area. So, and it's a left-sided, and mind you, this is a left lower inner quadrant. So you try to shield. So what as actually people sometimes think that, okay, you can just shield the heart. In this patient, the tumor bed would be right in the area where you will be applying your shield, lower inner quadrant of the left side. That's where her tumor bed is. So and people sometimes they're so focused on shielding the heart, they forget that you're shielding the tumor bed. We did a pattern of, failure study, loco-regional, and what we found, actually in 2 patients, we had a local recurrence under the cardiac shield. So which we had not noticed. So earlier we were also very, heart ko bachana, we have to save the heart. So I think in medial quadrant tumor, especially if it is lower medial quadrant, lower inner quadrant tumors, left-sided, you be very careful in applying your cardiac shield if you might shield that. So, and so plus if the survival benefit of IMC radiation is not proven as yet. So because that is the one reason. Second is the resource implication of treating IMC for every patient. I would not treat because that is not our standard practice as of now. In 2021, I may be doing it, 22, I may be doing it, but 2020, I don't do it.
Okay, sir. So, the next issue is the number of axillary lymph nodes. In this patient, there were 2 axillary lymph nodes. Suppose it would have been N0 axilla, PN0, or it would have been 7 lymph nodes say involved. So would your decision change or will it be same? Dr. D.N. Sharma, sir, please.
No, we will not change the decision even if the 7 or 8 lymph nodes are positive, because IMC radiation does not have the benefit, especially if the patient has a left side tumor. It will have more of a cardiac morbidity issues rather than the benefit. So we don't have the policy of treating the IMC treatment, even though the nodes are. But my question, if you, Dr. Prexy, if you allow me, I have a question for your surgeon. Why did he dissect the axilla? See, now is he not aware? Who was the surgeon by the? Is Dr. Arun?
Dr. D.N. Sharma.
Sorry, I'm teasing you, Dr. Arun. I'm teasing you because
No, I agree with that. So the thing is, till now we have not fully accepted the ECOSOC V11 guidelines in India. And as of today, if we get a macrometastasis in the axilla, we are going ahead with the axillary dissection. So there are situations when we get a micrometastasis either in frozen section or in a paraffin section. Those are the only situations where we are not doing an axillary dissection. So that has been the practice. I know gradually we may change to more, but there has been a lot of debate in surgical forums about this.
And thank you very much. Thank you.
May I make a comment, sir?
Yeah, please.
So I think the tumor size was more than 3 centimeters. So they have that we have to use a caution when we are avoiding lymph node dissection. If it is a tumor more than 3 to 5, it's a gray area. So
absolutely,
it is a grade 3 tumor, more than 3 centimeters. Because in this particular subgroup itself, in the dissection group, they found that 24 to 27% node positivity was there. So it was a cautionary group. Maybe that is why they went ahead with the dissection. Had it been less than 3 centimeters, I think then...
No, Dr. Kanika, I am being honest when I'm saying, sir, even if it was a 2.5 centimeter grade 3 single macrometastasis, I would still today do an axillary dissection.
Yes,
so only if I find a micrometastasis, not on frozen but on paraffin, that is a situation where we are avoiding. So this is the current practice. It is possible after, as Dr. Rajiv said, maybe in 2021 we might change.
So this is the same practice with our surgical colleagues as well, So that's why I asked this question, because even if the lymph node, even the primary size is less than 3 centimeters, they will still do the same surgery,
Dr. Arun, I am Dr. Madish. Yeah, in how many patients do you do this ultrasound, axillary ultrasound? Do you do
See, nowadays we have started a routine use of axillary ultrasound for all patients who are going for surgery. So basically, we do an ultrasound. If there is an abnormal node, FNAC, if FNAC is positive, then we proceed to an axillary dissection straight away, unless the patient is for neoadjuvant therapy. If the FNAC is negative, then the patient goes for sentinel lymph node biopsy.
And do you compare the sentinel node versus ultrasound? And if it is negative, you go for ultrasound only, not sentinel even node biopsy also, observation also.
See, as of today, not doing
there are
even
few
a
trials.
sentinel.
I'm asking because there are few trials which are also going on.
No, I know sound trial is going on, which is looking at this aspect of avoiding a axillary sentinel node biopsy also. But as of today, again, it is not become part of the routine care. So if the axillary ultrasound is negative or FNAC is negative, we do a sentinel node biopsy. So that is the current protocol.
My question is Dr. Sareen or Dr. DN, that you are saying that even 7 nodes are positive, even then also you will not do IMC?
Dr. Manish, no, unfortunately, no, we don't do that because there is no clear benefit, especially in left side tumors. It will have more of cardiac morbidity issues. So there is no concrete
but
benefit.
That is okay if you can say, yeah, I fully understand that whatever Dr. Rajiv Sareen was saying, that lower inner quadrant is very difficult, and most of the time we are not able, whatever save, but we are not able to save cardiac properly and all these things. But otherwise, in general, is it not an indication?
Dr. Munish, actually, theoretically, it might be an indication, but you know, somehow it doesn't not shown benefit consistently in the various trial. So you can argue this. You are very right. I mean, this is an arguable point, but somehow you have to have a policy. You know, our policy is not to treat the IMN node, especially if the left side tumor with this kind of scenario. You know, so
rather I would say there are few trials. Even MA20 has shown very clearly that a triple negative versus ERPR positive, there was a difference in benefit of RNI.
But this is ERPR positive, Manish. This is ERPR.
That's what I'm saying. That's what I'm saying. That if ERPR positive, the advantage of RNI was not much in comparison to triple negative in MA20.
I agree. This is you will have a varied practice for these kind of tumors across the centers. You know, not everybody will be happy doing the IMN irradiation. You know.
Dr. Sareen, what do you say? What do you say? Do you, Dr. Sareen, do you change your?
Let Dr. Kanika say she had a point. I gave a full talk on this, then I will say.
Can I make a point?
Yes.
Yeah, so see, I think just the numbers is not the correct way of taking a call. I think we need to also see the other tumor biology, the grade of the tumor. We really don't know the LVSI status, although ERPR is positive. So I think we need to take into these factors also account.
LVSI is also negative, no LVI, no PNI.
Yeah, okay. Then so these are the factors which are also to be considered when we are talking of less than 4 lymph nodes. Above 4, I think there is a benefit, although benefit I don't know is primarily because of radiation, and there is a heterogeneity. I think the big question which is there is that these trials were conducted when we were not using the systemic therapy of today's era. So I think that's
what I agree with you, but DN said no, that even if 7 axillary lymph nodes are positive, I'll not go for IMN.
I'm being honest, Manish. I mean, whatever.
No, you are very honest. I know.
Okay. Can we have Dr. Anushil also give his comments? He's there in the panel. So.
Yes, Anushil, please add to the confusion.
Internal mammary radiation, I would be very straightforward. I would give internal mammary radiation only if I see that there is an internal mammary node that is positive, that has come.
Thank you for agreeing, Mansil.
That is the only indication in my mind for treating internal mammary.
Very good. So you see the variation in the practice, Manish. You see the variation here.
Whatever evidence is there in literature, show me one piece of evidence where adding internal mammary radiation to regional nodal irradiation increases the benefit. Show me one piece of evidence in literature that tells you that. You may have different guidelines, and different guidelines are actually confusing the oncologists.
Very right.
I feel that you get benefit only in a select group. Probably, I think it's wise only to treat if they are actually looking positive, they're looking involved. Then only, just 2 or 3 months ago, you had this very important, I would say, data coming from Europe, which told us that talked about the acute coronary events after internal mammary radiotherapy. And those patients who develop acute coronary events after breast irradiation, internal mammary radiation has turned out to be an important factor in terms that their outcome, if they had received internal mammary radiation, is much worse compared if they had not received internal mammary radiation. So all this bit of data put together.
But Anushil,
radiation.
Anushil, if you see in MA20, what most of the time we quote, there was no difference in cardiac toxicity, 0.9, 0.4. What was that difference? Okay. IMC versus no IMC.
See, I agree what you're saying. The thing is, what did MA20 tell us? Did it show any frank survival benefit? That is point number one.
That was okay, but DFS...
No, please listen to me now. Please listen. It did not show any frank survival benefit. And whatever benefit it was telling us, it was for comprehensive, whatever nodal irradiation, including CF, axilla, internal mammary. And then it also told us the high rates of lymphedema if you gave such comprehensive internal mammary irradiation. Yes, the cardiac thing in their study did not come out. Now it depends on how they did the assessment and how vigorous was their follow-up. But there is umpteen data that we'd see it in routine practice. If we include internal mammary, don't the cardiac doses go up? Everyone knows they go up. And in my practice, if the mean cardiac dose is around 3 gray for left-sided breast cancer, if I treat internal mammary, it goes to 6 to 7 gray. That is what I see in my practice. And we have evidence that more cardiac dose, it is going to lead to toxicity. Now, if people are not willing to believe it, that's fine.
So now I think we should move on to the next question.
Yeah, Dr. Prekshi, next case. Yeah,
in view of the fact that most of the panelists are not using IMC radiation, so my next question goes to Dr. Manish. So since you are following the IMC,
No, I'm not following. I'm just discussing.
To this patient, had this patient so suppose if this patient was having a history of smoking and she is also having a history of ischemic heart disease, say she had an MI 5 years back, she had an angioplasty. As of now, her ejection fraction is 55%. But in this scenario, would you still like to give IMC in this patient?
No. See, that's what I'm saying. As even Dr. Rajiv Srin said, this particular patient is very, very difficult for IMC. It is not a candidate for IMC. Lower inner quadrant, and in my opinion, that ERPR positive and that 213 lymph node only, he's not a candidate for IMC. I'm just, I agree with you fully. Yeah.
Okay, sir. So, fine. Dr. Kanika, ma'am, what would be your opinion?
I think when we are defining a subgroup, these are the factors which we have to take into account. Her cardiac morbidity again forbids us to do IMC in 2 nodes. So it is not just the number which I was saying. You have to take into account a lot of other factors, patient's age, the other biological variables. So as she has cardiac problems, I think this is the situation where you would burn your hands by giving IMC.
Okay.
Dr. Prekshi, next case, I think we can go to you.
Okay, sir. Fine.
So you've just mentioned biological subtype. I think we have very esteemed panelists with us. If they can tell us, like the literature says that there are some biological gene panels, just like Oncotype DX, which can guide us in selection of patients for RNI. So, Sareen sir, so you are into so much of genetics, whether you can put some light onto that.
They are not as well validated as they are for using them for deciding adjuvant systemic therapy or benefit. So, I mean, it is still, I would say, that is work in progress.
Right.
One day maybe they will be, but not as of now.
So, let us now move to case number 2. So, this is about a 64-year lady with...
Sorry, can I interrupt?
Yeah, sure, sir.
Why did you ignore the last question? I thought it was important. Which technique would you use?
So since anybody is not giving radiation to IMC, then what?
No. I mean, You have instances when node is positive. I mean, I give radiation. Then it's not that I don't give radiation to those people.
Okay, fine. So, sir, now please you tell. So, which techniques do you follow? Whether photon only, photon plus electron, forward IMRT,
we should begin with Dr. Munish. He does it most.
No, I'm not doing. I'm asking. Hello?
Dr. Munish, what technique do you use?
Which one? Well, I'm saying that.
Not in this patient. Not in this patient. Whenever we are using IMC.
You can make this question hypothetical. If one has to do it, then what? So I think we should discuss.
Suppose in a patient, the indication is to give IMC. So which technique do you follow in a left-sided breast cancer? Dr. Manish, sir, please.
Dr. Manish, yeah, kindly give your opinion.
Manish, where is he?
Yes, I think is not there. So anyone from the panel?
Dr. Kanika?
I think Dr. Anashil or Dr. Kanika could take that.
In fact, I'm getting a response from one of the participants. They say that they go for DIBH in these cases.
I think we are the IMRT babies sitting on the corporate hospitals practicing more so the high-end techniques. So if we really have to embark upon IMN, first of all, the weakest link I would say is the contouring. So we are doing vessel-based if possible, because now the RTOG, which was telling a 1 centimeter margin, has been found to be very, very detrimental in terms of controlling hard doses. So we are doing vessel-based, and ProCarb, you do that, or there are newer guidelines where they have shown that you don't have to go into the pleural interface. And DIBH is, if you have DIBH, that is the only thing which can actually control your cardiac doses. Other than that, I really don't think that you can really add much by if you are doing RNI, then 3D CRT you cannot do. IMRT, we might end up giving you cardiac doses which are not controlled unless you do DIBH. Dr. Anushil, anything else?
So our class solution for this is to give small tangential arcs. And I think that is the best way we can cover the target area and spare heart. And usually they are around 30-degree arcs by tangential. And in my experience, if you have to treat the internal mammary area, I think this is the way I have liked. I know people would have other experiences as well, but this is the technique that I use in my clinic.
I think for IMC, there is no one standard technique which will, so I think it all depends upon the patient's anatomy, external anatomy, internal anatomy, cardiac anatomy, patient, where is the location of the tumor, like, if the tumor bed is near that, and how cooperative the patient is. And of course, in centers like ours, how many patients are already on DIBH on the machine as of now, how many more we can push. And I think in a private setting, whether the patient can afford. So these are the real life scenarios which we take into account. So there is no one technique which will be ideal for it. In many patients, just simple partial wide tangent would also cover, depending upon the heart is a little narrow and lower down, even that. But in many patients, partial wide tangent, which becomes very easy, will not really help. You are still irradiating part of the heart. So I think this is where we actually have to individualize the planning and decide what is best for this patient and what you can actually do it in your setting. That also is important.
I think Dr. Prekshi, we can move on to the next patient now. We are running late.
Sure, sir. So let us move to the second case. This is about a 64 years lady with history of hypertension who had a lump in right breast, lower outer quadrant. Full history and complete physical examination. She landed up in CT4B and 2A. Skin was thickened and the lump was fixed to the skin. Multiple axillary lymph nodes were present. It was grade 2 IDC, ERPR positive and HER2 negative. She was given neoadjuvant chemotherapy, 4AC, followed by 12 weekly paclitaxel. Whole body PET CT was done, which showed a partial response. This lesion size at the primary site decreased. However, the axillary lymph nodes did not respond so well. Then she was taken up for MRM. The postoperative histopathology showed a residual tumor of 1.9 centimeters in size. LVI was present. And in axilla, 13 out of 14 lymph nodes were positive along with extranodal extension. So it was YP, T1C, and 3A. So my question goes to Dr. Anushil Munshi. Sir, what would be your radiation prescription in this patient?
I'll disappoint you again, I feel.
You will not irradiate axilla.
I would not irradiate axilla. I would not irradiate internal mammary. I would treat the local site and the supraclavicular fossa, and I would actually be very careful that I would be treating the undissected portion of the region, the SCF axillary, whatever region that is, because nowadays we have quite a bit of evidence that it's important to keep away from the dissected portion if you want to avoid subsequent lymphedema. So that's what the subsequent EURTC trial also told us after the initial MA20 results, which were showing a bit of problem. And that's how they modified their portals to avoid the dissected portion of the axilla. And that's what I would be doing. It's a supraclavicular portal plus local radiation.
Dr. Kanika, ma'am, what would be your opinion?
I believe when the surgeons dissect out the axilla, they practically leave nothing there to radiate. So I agree by Dr. Munshi that if it is a good dissection, it's a full dissection, you practically are radiating the fat which is there. Rather, fat is also dissected out. So SCF I would definitely include, and axilla ENE something, there is ENE as well as heavy nodal burden. In some situations in high grade tumors, I do go for axillary radiation.
So ma'am, you will go for axillary radiation in this case?
Heavy nodal burden with ENE. There are two parameters.
Yeah. Okay, okay. So what would be the incidence of axillary recurrence in such a patient? Dr. Manish, sir, you there? So might be some network issues. Dr. D.N. Sharma, sir?
He is also having some network issues. Dr. Sareen, please. Dr. Rajiv Sareen.
Yeah. So, this is one thing which has really always bothered me. Like in Tata, see, a lot of your practices depends where you train. Okay. So I trained at Tata Hospital, and there Anushil will bear me out. We rarely ever irradiated axilla. And outside, first when the talks, when I was people, I said, why is it irradiating axilla? Then I realized almost everyone is irradiating axilla. In north, in south, east, I do not know, except Bombay. And then I think, then I realized that, see, your decision, no, we don't want a recurrence. The quality of surgery is so heterogeneous, plus the quality of pathology reporting. Only now in the last 5 or 10 years, it has become more homogeneous and, better the qualities. But before that, everyone thought they can operate breast cancer. They would do just whatever nodes. I think most of them were actually doing low axillary dissection rather than doing a proper axillary clearance. And so I think many people irradiating axilla almost routinely for a node positive. What they did in those days was the right thing, because otherwise patient would have had excess recurrence because the surgery and pathology was suboptimal. But in Tata Hospital, we always had specialist breast surgeons who did always, I mean, they were too zealous, so overzealous, they were 20, 30 nodes, they were routinely removed. So I think in a proper axillary clearance, unless until there's a residual disease, then only we add. And the reason I am hesitant in axillary RT like IMC, because we have not forgotten the OPDs 2030, where there will be so many women with big fat arms, who would hardly use that arms. And that has reduced. Now we rarely see such patient, only one odd patient, because extent of axillary surgery is less and we don't add radiotherapy to that. So axilla, whenever you add two modalities like axillary clearance, full dissection plus RT, there will be morbidity. So we use it very selectively. And these are the patients who are what you are describing, who had very extensive disease, perinodal extension. They may actually fail elsewhere also. So this is an issue which is I don't think anyone in the world has the clear answer, because no study has. All the MA20 and all, they were not that kind of patient, subset of patient that we are describing here. So type of patient where we really worry they may have an axillary recurrence. And I think the most important factor here is the surgeon who has operated. So he or she can have a major impact on the axillary, apart from the biology of the disease.
We have Dr. Beriwal there. He has commented in the chat box. Can we invite a comment from him?
Sushil. Are you there?
Dr. Beriwal, kindly unmute yourself for your comment. I think it's not maybe some network problem. Dr. Prekshi, you continue.
Okay, last question on this case is, does a completely dissected axilla by an oncosurgeon in any way need radiation at any time? So, Dr. Anushil, please.
I'm a repeat offender. So completely dissected axilla, I mean, unless the surgeon tells me he has left disease there, he has put clips there, he has left the disease there, that is the only situation I'll go and treat that portion of the axilla. Otherwise, these arguments of number of nodes and this thing, they don't really convince me because I don't see any frank evidence. I see evidence of lymphedema when you do double treatment of these regions, but I don't see evidence of benefit happening. So that is what deters me from going all out and treating. That is one part of the thing. The second thing that you have not brought out is the complexity of the plan that you land up in. Whether you are putting internal mammary or axilla or this thing, suddenly you find that the treatment plan and physicists, they are all scratching their heads as to what plan has to be made, what are the beams that have to be placed, what contouring, because if you see the contouring itself, there is a discrepancy even between RTOG and URTC guidelines if you see in the literature, whether it's the breast or the regional nodal irradiation target volumes. So where is the homogeneity, where is the clarity? So, and where is the benefit, proof of benefit? So that is what keeps me away from unnecessarily treating the axilla by radiation.
Well, Dr. Anushil, you warm my heart. I think in last nearly 25 years, I have, as an oncosurgeon, always insisted with my radiation oncologist not to treat the axilla when I have done the dissection. And I'm lucky to have Dr. Dinesh who's agreed to follow this protocol. And I agree that it basically increases the arm edema without really giving too much of benefit. But thank you.
I agree, and I don't remember last time when I had treated axilla, maybe a decade and a half ago. Because in last so many times I haven't get partially dissected axilla, so I have not treated that. Even if I am getting extra nodal extension, I have not treated axilla.
See, sir, since we all sit in tertiary care, most surgeons who you practice with, you would know their practices, but we get patients from outside. We get patients who have been operated by general surgeons. So I don't think we can just stretch that statement to everything. We would not know. They would not comment that they've left disease there.
As I said, if the patient has been operated by a surgeon you do not know and has been reported by a pathologist you do not know, you have to think about it.
ये ओमवती वाला है ना कि इसलिए sentinel वाला.
And just one more thing, I will tell you that we did about 100 consecutive loco-regional recurrences. So actually when you don't do a proper audit, you think axillary recurrences are rare, very rare. But they're not as rare, but isolated axillary recurrences are very rare. Where there is everything in disease is controlled and the recurrence is only in the axilla. So Sushil Beriwal, he's not here, but he has just sent a article, link. I just quickly saw that with high nodal burden, more than 90% positive would treat axilla. So in that study published in 2006 in Red Journal, it showed that patients who had a high axillary, burden, the ratio, they have a high, and by given RT, you can reduce it. But by reducing it, actually, this is part of the regional control. It is not the entire loco-regional controls. And maybe a axillary control would improve, but the overall loco-regional control would improve because we don't see too many isolated local axillary failures. Would the overall survival improve or not? Or the quality of life? So when you don't improve the overall survival, then quality of life becomes an important arbiter.
Agreed. We have to look at the individual patient with its individual merits and demerits. Shall we proceed to case 3? It's already 8 o'clock.
So,
okay, I think we can stop it.
I think, yeah.
Okay.
Thank you, Dr. Prekshi, and all the panelists and the speakers. It was a wonderful interactive session with a very hot and a very controversial kind of topic in which we get varied opinions. I'll invite Dr. Arun Goyal for the concluding remarks.
No, I think it is really wonderful. The objective of this whole webinar was to bring out the debate and the difference of opinion which is there. And I think it was very well brought out in the talks as well as in the panel discussions. And as we know that discussions are endless, we could have more cases and more discussions, but we have to stop. We have already overshot by half an hour. So I would like to thank all the speakers, all the panelists, and all the audience for really making it a very good session. And I'm really sorry for whatever happened in between as a part of some hacker getting in. We'll try to find out what is possible, how we can avoid that thing in future. Thank you.
Okay.
Thank you.
Thank you.
How do we leave the meeting?